Hey guys, Niko and Erin here from Redox. We're excited to chat with you today a little bit about EHRs and this interoperability problem and various approaches to trying to take a bite out of it. Really excited to have Erin join us. Recently came from Athenahealth. Want to give a little intro?
Hey guys, I'm Erin Trimble, VP of Business Development here at Redox. This is my fourth week on the job. Joined Redox from Athenahealth, where I worked on the More Disruption Please program, which focuses on innovation and partnerships. Excited to be here at Redox and help make healthcare a little bit better.
Cool. And my name is Niko Skievaski, if I forgot to mention. I'm one of the co-founders of Redox and focus on working with various application vendors and health systems and trying to help them figure out how to share data between each other through our platform. As many of you know, I used to work at Epic and spent some time there through that process of the rapid growth, meaningfully use all of that sort of history, and really excited to kind of share our unique perspectives in this space and what are the important initiatives out there as far as interoperability goes today. So,
before we dig into this, I think we all know that we're in a bit of a mess when it comes to interoperability in healthcare. But before we dig into the why and who is to blame, I think it might be helpful to talk about how we got here.
Yeah. And to set the stage, interoperability is a big problem. There are many flavors of interoperability. The sort of classical flavor of it is patient goes from hospital setting to their outpatient setting, or maybe they're in a different state. And how does the data follow the patient? That's kind of the continuity of care interoperability problem. There's also the application interoperability problem. There's a piece of software that wants to work with a health system or with a patient, and how do you make sure that software has the right clinical context for whatever value propositions they're delivering? So there's that application interoperability, both on the enterprise level as well as on the consumer level. How do consumer applications, things like Fitbit or your health kit on your phone or anything like that, how do they actually get access to that data? So it's a slightly different flavor of interoperability, and it's a wide spectrum. So to put some history behind this interoperability problem, we have to start with why it exists to begin with. And that goes back to the electronic health records and where they came from and how they were adopted. So if we take a step way back in time to the late 70s, early 80s, databases were just coming out in the world. They were being built on computers using huge hard drives like this hard drive on the wall behind us here, kilobytes of space in large physical locations. And someone had the great idea of what if we actually started putting medical data on these hard drives and organizing it. And there were a number of reasons why people wanted to do that. Some came from the perspective of research. If we stored data in a database, we could do more effective research. Others came from the perspective of it's really hard to process claims and send data to insurance companies so providers and hospitals can get paid. So wouldn't it be great if we could store that data electronically and transmit it to get paid faster? But the main purpose of the EHR as it came out was, how do we take what we're doing on paper today on a clipboard when you're meeting with a patient and understanding their symptoms and what treatment plans we're going to put in place? How can we take that from paper and put it into a setting where we can easily enter that data into a computer, and that data can be stored and used for other purposes, like streamlining back office processes like billing, like getting access to the data to slice and dice it in different ways. And that's the theoretical promise of the EHR, is that if we digitize this data, we can use this data for more exciting things. Any technology goes through this proverbial technology adoption curve, where you have early stage companies innovating in the space, creating these pieces of technology. So you think back to the history of Epic and Cerner and Athena, back in the early days of EHRs, they were really innovating in the space and trying to figure out, how do we actually create a product that delivers this value to the health systems that are asking for it. And that's when they're getting feedback from customers, they're iterating on the product quickly, they're putting features into it. As those products grew and as it went from the very early innovators to the early adopters, there's this proverbial chasm that exists that essentially means that technology needs to mature enough to meet the needs of the early, like the mass population, the majority of hospitals and clinics and providers out there. typically for technology to cross that chasm, it needs to have it needs to have a full feature set. It needs to be enterprise ready. It needs to be rock solid as far as security and infrastructure goes. It needs to cross that chasm based on meeting the demands. And if you think about, easy example, you think about MP3s. We had a ton of MP3 players. I had a Rio that held 13 songs on it, like just a little bit better than a CD. That was before MP3 players crossed the chasm, and it took innovation like the iPod to pull MP3 players into the mainstream and get everybody using them. And it was because the iPod was massively better than its predecessors, and that spurred the demand for that product and pulled it as far as the market goes. The reason why I go into this technology adoption is because that's not what happened in the electronic medical record space. Electronic medical records were being worked on and being innovated innovated upon, and they were in those early stages of technology adoption where customer feedback was really important, where quick turnaround time, delighting the customers, was the most important thing you could possibly do. And that's when we realized as an economy that electronic medical records are really freaking good at. We should adopt those across the entire, like every single place you can get care should have medical records implemented. And meaningful use, which was part of the High Tech Act, 2009, right? Our economy is going into a tailspin. How do we put money into it in smart ways to stimulate the economy? A part of that High Tech Act was devoted to putting dollars into the economy, $20 billion, to spur the adoption of medical records. And whenever you put subsidies in place like this, from a policy perspective, you have to figure out how are you going to get people to, well, how do you define what that means to be a medical record? And how do we actually incentivize people to meaningfully use these medical records? So like the title of the legislation, meaningful use, was designed to incentivize doctors, incentivize hospitals to adopt medical records and use them meaningfully. But the specifications of what meaningful means suddenly went from a discussion between a customer and a vendor to a checklist created by the government to say, this is what it means to meaningfully use a medical record. These are the features a medical record needs to have. And suddenly we had medical records come to the mainstream, come across the chasm, being used by every organization in the country. And any established medical organization is most likely using a medical record these days. We're definitely adopted across the industry. But the natural forces that it would typically take a product to mature across that chasm didn't happen with medical records because of this artificial subsidy from the government. And I'm not saying that the policy was a huge mistake, but it made it so the innovation of medical records didn't happen naturally. It made it so they happened based on the checklist that the government put forth. And now that checklist is there, we look to that regulation and say, what should have been better, what could have been better, and we come out with new regulation that continuously drives what features EHRs are creating. So that's kind of the landscape that we're coming from. And now we're in a place where notoriously the doctor you go to on one side of town cannot share the record with the doctor you go to on the other side of town. It's very common for you to see fax machines in existence in the wild in the healthcare space. They're not used anywhere else. I guess car dealerships might still use fax machines, but we're talking about
the only industry that keeps fax machines for production.
So that's the state of the art. How do we transmit medical records between facilities is faxing, and there are initiatives in place right now to try to solve that problem, but that's kind of where we are. So my job to answer that question was really to kind of give that historical background. Yeah, but like from that perspective, should the EMR vendors have been focusing on innovation? Like, are they to blame because they didn't focus on how to actually solve that problem as they were going through those regulatory cycles?
No, it's a good question, and I think EHRs get the bulk of the blame for this interoperability problem today, and I'm not sure that's entirely fair. And I honestly I have to sympathize with them a little bit. I mean, first off, like these vendors are incredibly resource constrained. Like you that you described have now in 2017 become, MU3 quality measures and everything else that's now been mushed into MACRA, and EHRs are expected to keep up with all of this. I think MACRA is actually a great example. I think the ruling was up in the air for several months. It finally got finalized, I think, in October of last year, and by January, practices were expected to start adhering to it. And what they do is they look to their EHR vendor as kind of a trusted partner to help ensure that they're able to adhere to these new regulations. And so you're giving these vendors a 3-month timeline to do whatever the necessary development is to make that happen. I think it's important to understand that like EHRs, while they get kind of a bad rap, aren't evil companies. They're trying to listen to their customers. They're trying to keep up with regulations, and they're trying to run good businesses. I mean, I think we don't blame other companies when they're maximizing profits and growing revenues and operating a successful business. And in many ways, these EHRs are operating in line with their economic incentives. And unfortunately, for many, I think that business model just isn't one that always fosters interoperability. So, I don't know, Niko, coming from Epic, I mean, how does their model kind of help or hinder this interoperability need?
Yeah, Epic takes a lot of the heat in this discussion around, they've been called data blockers. I honestly feel, coming from that background and working in this space of interoperability, that in many ways that Epic and many of the other EHR vendors are the scapegoat for the problem. The way that at least from my experience working with Epic and Cerner and a lot of the bigger hospital and health system side EHR vendors is that they are very, very customer focused. So they listen to the health systems that they work with. They work with the largest health systems in the world, and these organizations need highly customized enterprise level products that take a lot of development to and a lot of customization to meet the needs of.
EHR is not an easy thing to build.
So the EHR functionality essentially touches every part of a health system, from actual clinical care and everyone involved in the care team to the entire back office operations and everything that entails, like medical billing and coding and resource planning and all of the like inventory management. So it's a huge piece of software. The development priorities of electronic medical records, first and foremost, that customers are asking them to keep up with regulatory requirements. So a large part of their development workforce is trying to stick to the letter of the law. What is MAPRA telling them they need to do now, and how much time do they actually have to implement not only the features required to report on those quality measures, but also track the different activities in the EHR to make sure that they're reporting on them accurately. Tons of development work that goes into that functionality. Beyond what's required by regulations, they're listening to what their customers are asking for, just from a feature request perspective, like any software company does. They say, we would like streamlined workflows in this department. We would like, we're spinning up a dental practice. We need modules over there. And companies that deliver huge enterprise software like this have to be customer focused and listen to those demands. The challenge here is that because of the market that these very large EHR vendors serve, their customers are regional powerhouses. So if you think of the largest healthcare organization in the region that you live in, it's most likely using Epic or Cerner or Meditech or one of these very large EHR vendors. The business model of those health systems has some perverse incentives when it comes to sharing that data with other providers in a region. These are businesses when it comes down to it, and as we all know, the business of healthcare is in trouble. Health systems are seeing their profit margins shrink over the past few years, and as of lately, we've seen many of them go into the red, operate in the red for the past few years. That's spurring the consolidation in the market. When your hospital goes in the red, you look for someone to acquire it. People are acquiring hospitals to centralize, vertically integrate them and centralize the planning and resources to figure out if they can make them more profitable. When you're talking about a market like this that's under the constraints of the market constraints of their business, competition is very important. How do you make sure that you're treating patients and earning the business of patients so that they keep coming to your organization? In the consumer space, when a customer chooses to go shop at Walmart or chooses to shop at Target, we call that shopping, right? The consumer chooses where they want to go. In the healthcare industry, for a lot of these very large organizations, the term for a patient shopping between organizations is called leakage. That means the patient is leaving their organization outside of the network of their integrated delivery network system, and going somewhere else, and that's losing a customer. It's them leaking from the network, and it's those sorts of constraints that make it so they aren't going to freely open up and share all of the clinical data that they have in their databases that is really an asset to the organization. They're not going to share that openly, just like asking Walmart to share its customer database or to share its inventory management system with its competitors. It's just not going to happen. And it might be unfair to compare the cutthroat retail world to healthcare, but at the end of the day, these are businesses, and they're businesses that are trying to innovate their business models and survive, and sharing valuable assets openly, like we'd want them to do for the good of the public, is sometimes at odds with their business models. That's something that you're not going to hear a healthcare executive say. It's something that you're not going to hear an EHR vendor say. But from a purely sort of market analysis perspective, it's the reality. And just understanding their constraints, it's something that it's a troubling sort of problem to try to understand. So that's very much the perspective of the large health system. It's where a lot of healthcare happens in the country, but a lot of healthcare also happens with smaller providers who still run their practice like a small business. They team up with a couple other providers and start a clinic, and they use very different software. Yeah. So I'd love to ask Erin her opinion, coming from that world of smaller practices that operate like smaller businesses. What is the software they're using? Yeah. What are the constraints there, and how does that differ from this large EHR space?
Yeah, so it's a great question. I think Athenahealth and other kind of ambulatory outpatient EHR vendors have had to build a competency around integrating with the likes of Epic and Cerner, especially when they have to kind of coexist in these ecosystems where Epic and Cerner is installed at that large health system. And I think the approach that some of these EHRs have taken is one where they see interoperability and enabling connectivity to other solutions is actually a way to make their product stickier. I mean, if the EHR becomes this backbone upon which I can plug in my telehealth solution or my patient engagement solution and all these array of different apps and vendors that I want to use, it makes it a lot harder to rip that EHR out at the end of the day. And so I think some EHRs like Athena, Allscripts, a handful of others have kind of gone above and beyond in creating their own developer programs and proprietary APIs and even these sort of app stores where you can shop for, or their providers and their clients can shop for solutions that meet their needs. And I think those programs are great, and they're certainly forward thinking. I mean, here you have this little bubble of interoperability, and it works pretty well for those practices. But I think that at the end of the day, it's only solving that interoperability problem in that bubble, in that vendor specific bubble. And I think the challenge we face is like it's hard to see a day where these EHR specific programs really solve interoperability for the industry as a whole.
So I want to touch on something there real quick. So a lot of these app store models is focused on, we defined at the beginning, the application interoperability problem.
Yeah.
A lot of these types of programs that, they do telemedicine, they do remote patient monitoring, they do patient engagement, and a lot of the functionality of those sort of point solutions is starting to get overlap with the realm of what functionality an EHR provides. Why does an EHR vendor, how are they okay with allowing a potential kind of almost competitive product to be used in their system? Like, why does that make sense?
It's a good question, and some of them aren't, to be perfectly honest. I think if you look at those different app stores, you'd find some that are more open to what you would consider competitive solutions than others. I think the more forward-thinking EHRs are ones that don't see them as being an EHR vendor forever, right? They see, this EHR as potentially an app that plugs into a backbone, and that's where I think the most forward-thinking vendors stand to help us really solve this problem.
So if they all thought that way, could EHR solve this problem?
At the end of the day, they're still resource-constrained businesses that have to adhere to certain, interoperability standards, and it's a tough market to be in. And so, and I don't know, how well do we really see them all playing with each other when they're competitors?
Yeah,
right?
I think that's a huge point, right? Like they are competitors. They have a clear competitive pressure to not replace themselves with their competitor. So it's an interesting kind of conundrum that even the vendors find themselves in, where they can open up as much as they want within their ecosystem, but what incentives do they have to open their ecosystem up to their direct competitors?
Exactly. Yeah, and I don't know, now people are kind of, proclaiming FHIR is this new vendor agnostic solution. I mean, I don't know, do you think that's the answer, Niko?
Yeah, so FHIR, for those of you unfamiliar with FHIR, FHIR is stands for Fast Healthcare Interoperability Resource. So it's not fire like flames. It's it's an acronym, and it is essentially the latest iteration of an attempt for us as a community of software developer vendors in the ecosystem to come together and agree upon, this is how we want to exchange data. This is the language we want to use to communicate. So we are ecstatic to be part of this initiative to push the adoption of this new standard. But really the basis for coming up with the new way that we're going to exchange data is by looking at the past and saying, what did we mess up in the prior iterations of our standards? Yeah. So early on, we had HL7 version 2. We don't know what happened with version 1, but version 2 was the thing that is currently still used in every single health system around the country with every single EHR. HL7 version 2 is in use, and there were distinct limitations to the standard. There was far too much optionality in what an EHR vendor can do with the standard, as well as too much optionality in what a health system can do with that standard itself. So it's almost like we came up with a language and then said, grammar's not important to us. You can use these words however you want, but you can place them in whatever order you need to, and don't bother writing down how you chose to do that. And if you look at how HL7 was adopted, first, the EHR vendors customized that standard. Second, the EHR vendors customized the workflow for their customers who are asking for specific things to be added, right? The different patient lists, the different appointment types for their specific organization. All of that added and changed the grammar of these standards, if you will, to use this metaphor in a verbose way. So when we're looking at how do we actually move FHIR forward, we look to the past and say, these were the problems that existed that got us into the place we're in now. That's HL7 version 2. We had another try at it, a decade ago, and continuing on today with version 3 of HL7, which was really around the consolidated document architecture, CDAs. CDAs was a new approach. Instead of a crazy pipe delimited gobbledygook of data, we used XML, and XML is phenomenally better. It has labels for fields, right? We say first name and then we write the first name. Whereas with HL7 version 2, it just said George, and no one knew if that was the doctor's name or the patient's name unless you actually were familiar with the grammar associated with what order these things go in. So that's what CDAs gave us. We learned from that process and said we need to make sure that we have labels on these things. We call a first name. We call a date of birth, and maybe we suggest a format for how to use a date. But again, with this additional attempt with CDAs and CCDs and this version 3 of HL7, there was too much optionality built into the standard. And optionality means, we suggest this is the way to do it, but you have some options in how you want to implement it. CDAs aren't useful to software developers right now. They are too inconsistent, and you can't, when you have inconsistency in data formats and data types, as a software developer trying to build software that works every single time, you can't require manual intervention and data cleaning and tons of processing just to get data out of the system. And with the second attempt at this, we for the most part still had a lot of the same problems that HL7 version 2 had, and it didn't replace HL7 version 2. Version 2 is still the most widely used interoperability standard out there. Like I said, used at every organization across the country. All the vendors are using it. All the vendors also do CDA. Some do it better than others. Some put more effort into it, but all of them met the requirement of the regulation to say, yes, I checked the box, I can operate using a standard. But today, if I go to my doctor here in town and ask for my medical record, which is required by the letter of the regulation, that I can get electronic access to my medical record, they will literally burn a DVD and give it to me, and it'll have a PDF of my medical record on an electronic version of it. And that PDF is based on the clinical document architecture format. Because it's not usable by a computer as a language to ingest and send out in a discrete way, they create a PDF of it. And I don't know about you, but my computer doesn't even have a DVD. I can't do anything with that. But that's just the challenge with regulations, is that the regulation had the best intention of saying we need to electronically enable access to this data. And the hope is if it's electronically enabled, that data can be used for other sorts of purposes. But without specifying exactly how that needs to happen, you can't get there. And I'm not saying we should specify exactly how it needs to happen, because that will limit it to that use case as well. So the regulatory approach to this is flawed in that when the regulation comes out, people build it to meet the needs of the regulation, to check the box. And as soon as they check the box with the minimum appropriateness, they turn back to their customer and say, what's next on your feature request list? And oftentimes that's not the highest priority for the health system, the provider group that they're working with, or the EHR vendor themselves. Getting back to FHIR, I forgot we were talking about. Getting back to FHIR, FHIR is, again, it's the next iteration of this attempt at trying to create a standard that we can all use. It's where we should go. We should move in this direction. Instead of XML this time, we're going with JSON. JSON, again, is worlds better. It's object-oriented. It can be much more opinionated in how we lay out the data. But in these meetings, so the way that FHIR is created is the vendors in the industry come together, sit in a room, get on phone calls, and create the standards themselves. In these meetings, everyone has their own agenda to put forth, what can we implement at the vendor that you might represent at the table there. And Redox is at these tables helping to create this. And the discussion that's being had is around how are we going to implement this? And does it need to be a hard and fast requirement that appointment types are these 5 appointment types? The health systems that use my software have 15 appointment types. How am I going to fit that into the model? And so in the model itself, we're seeing more and more optionality being created. And the more optionality that is put into a standard, the less valuable it is for the developers who actually have to use it. So while it is the direction we need to go in, there are constraints on the table that make it so that this language that we're creating is not going to be perfect. It's not going to be the Webster's dictionary plus whatever grammar books they give you to define how to actually use this. That's the challenge here. The other challenge is, even if we all agree on the language, even if we're all speaking English, we still haven't defined how we're going to communicate that language. So right now, Erin and I are speaking English to each other and to you through this tiny camera. That is the communication mechanism that we choose to communicate our language through. But I can also do it via email, via text message, via newsletter, sign up for our mailing list. Via Slack, which is our preferred way of communicating. The communication protocol is still not defined, and there's still not a centralized place. At our company, we use Slack to communicate, which means it's a centralized place where we all go to communicate with each other. Where is that centralized place in the healthcare ecosystem? Even if we all choose to use English, there's still not the phone line that we're all going to pick up and communicate with each other on. So there's some problems that FHIR didn't set out to solve that problem. But as FHIR became this new hope in the industry, I think it took on a bigger picture. The scope creeped in the minds and hearts of the people who had this problem. The scope creeped there. The scope did not creep in the committee meeting run by HL7 where we're trying to actually create something usable by developers. It's a piece of the problem. But interoperability, we can solve it by looking backwards at the standards that failed in different ways in the past and try to create something better. But that in itself is a backwards-looking approach. There will always be more functionality required by vendors as they come about, right? We're seeing more and more different types of innovation happening in the digital health space that will push the limits of whatever we create. So we need this continuously evolving process to understand what is the functionality required by innovation and what is the data available and how do we connect those two things. And that's always going to be a moving target. So FHIR cannot solve interoperability because interoperability cannot be solved. It's a little bit of a cop-out. EHRs cannot solve interoperability because it cannot be solved. It's an asymptote. It's perfect, and we will approach it, and things will get better in the coming years. And it'll be EHRs stepping up and adopting FHIR and putting out better interfaces and trying to standardize. It'll be standards bodies pushing forth better and better standards. It'll be the regulatory space making that baseline of minimum requirements that everyone has to abide by to get this stuff out there. But we're still not at a place where we're going to see, you know, that model where we can connect once using the exact same language and developers have that experience of scaling an application on top of that infrastructure. Sorry. At Redox, we think a lot about FHIR and about this problem, and we obviously care a lot about it. And you know, we're not trying. Where do we fit in though? Yeah. Okay. So that's a good segue, right? Well, like, what is our approach? What is the Redox approach to to solving this problem? So you know, I've said it's not the EHR's faults, right? We talked about their constraints from a regulatory environment, their business models, who their customers are. It's not the customer's faults either, the health systems and providers, because this problem is so much bigger than their organizations, and their organizations need to care about how they actually evolve their business model to remain viable in this future. That's still so much up in the air. It's not the regulator's fault for not picking the right rules, because the rules will never be good enough and can never be forward-thinking enough to meet the requirements of future vendors. So taking all of this into account, what Redox does is we look at the vendors who are out there. So we've always had a developer-first approach. We work with healthcare software developers across the digital health ecosystem who are making all sorts of different solutions. And first and foremost, we listen to what they're trying to build. And we say, okay, you're building a telemedicine solution. What is the data you need from the EHR, and when do you need it? And then we go back to our EHR experience, working with these standards, working with these vendors, and understand what is the best and most appropriate way to pull data out of any of these EHRs and whatever standard they might exist in, and create a consistent developer experience for the guy making the application, or girl, sorry, making the applications out there who are the ones who are innovating. So it's that developer first approach that I think makes Redox unique. The second thing, you know, just beyond understanding where the functionality is moving and how do we adapt our current worldview into that, is that not only are we taking the data and standardizing it in a way that works across all the different EHR vendors, we are also managing that communication mechanism. So we are saying, go to this place in the API space, go to this URL where you can hit an endpoint, and that endpoint is your gateway to any EHR, to any health system. It's the connect once, connect all network. And this networked approach to interoperability, yeah, it makes our life easier, right? Because we have a centralized model. But what it does is it creates an ecosystem from an economics perspective where we're adding a node onto a network, and adding a node to a network has a fixed cost. But once that fixed cost is absorbed by the network, that node can be reused by the entire ecosystem. So we have a model where every node that we add on increases the benefit for the ecosystem. So it's increasing marginal benefit per additional node. We also have a model where as we add more nodes and as people are more comfortable with our standard, and as Redox gets better at working with health systems and standards and connecting them, our costs are drastically diminishing. the first health system that we went live with, it literally took us a year since we launched Redox to go live with the first health system, which was Hackensack University Medical Center in New Jersey. It took us a year to do that, figure out our business model, figure out our approach to it, figure out our support systems, how we're going to connect up, the communication mechanism, the standard that we're going to, standardized way we're going to communicate this data. That took a year. These days, we're turning on new health systems and applications every single week in projects that take as little as 48 hours, where we have an application day one going to staging, day two going to production. And that's because of the efficiency gains of this networked approach, where the application connects to the network and the health system connects to the network. And it's no longer a technical feat to get them communicating. We can work with the standard that the health system and EHR are using. We can work with the API requirements that the vendor wants and simply make sure that access is granted and turn it on. That's what networked interoperability means to us. And by no means am I saying that Redox solves this interoperability problem, but what we do is we work with the inconsistency that's out there, and we listen to the innovators, and we create something that our profit motive is aligned with solving the problem of the vendor and the health system and the EHR to interoperate. That is our service that we provide, and we want to get better and faster at it, and we want to make it commoditized across the industry and make it so it is wildly cheaper to plug in and use us than it is to do it yourself. Because these are all things you can do yourself. You can build a custom connection to the EHR yourself. That's how it's been done in the past. It's not rocket science. We're not doing this something that you couldn't do, but because of how our network works, it needs to be a no-brainer that it's just so much easier to use us. And from a developer's point of view, the full stack of development isn't that interesting. The most interesting pieces are the very top layer, the features that make that application unique. Everything else in that stack, the hosting, the application layer, the authentication layer, those are things that could and should be standardized. They could and should be secured in a way that we know is not dependent on that small vendor, but is something standardized and trusted across the industry. That's what we're trying to do with this application layer, centralize and standardize it. I feel like I've gotten on too many soapboxes here.
Should we? I think that's all we've got. Should we turn to some questions?
Yeah. What did we miss? What are the questions that we have out there? Let's check out what you guys asked. So to recap here, at the bottom of this webinar screen here on Crowdcast, there's a big orange button that says ask a question or suggest a topic. What we're going to do is go through those questions, vote up, click the up button to vote up the top one, and we'll start at the top and work our way down. So just ask your questions there, and we'll try to get to as many as we can over the next 20 minutes or so. So let's see, the first one here, 5 votes from Ty. Thank you for asking. What are your thoughts on how Apple is potentially getting into the interoperability game by collecting healthcare data on their phones?
I think it's awesome.
Yeah,
right?
it's phenomenal, right? Every one of us, I think, the smartphone is definitely a piece of software that has crossed the chasm and is now in the pockets of nearly everybody. It would make sense that we should put our clinical data there. I think one of the things in this interoperability space that gets missed a lot of the times is that the patient is the one that's moving between the contexts of care. The patient is the one that could potentially be engaged in using their data to change their behaviors. The patient needs to be at the center of this, and
they need to own their data and have real-time practical access to it.
Yeah. The patient does not have a DVD drive and cannot read a PDF. They need that context in an application to build the engagement required. We haven't seen the engagement from the consumer brands in the healthcare space required to actually engage consumers. So Apple's step into this space, I think, could potentially be groundbreaking, and we're absolutely inspired by it. They've created their health sort of platform where healthcare applications should be built upon that. And these are applications that focus on the consumer space, on a patient, on me and you, pulling out of our pocket and using some application that could engage us. Them getting involved in this interoperability space then means that they came to the table with us in Argonaut at FHIR to throw their hat in the ring and say, guys, we need to figure out a way to bring this to consumers as well, which we absolutely should do. it's very likely that the next iteration of their health product will include FHIR resources in it. And that's a huge step forward, because now we're getting on the same page on the enterprise side as well as the consumer side with sharing that language. There is still a place, though, for figuring out how we communicate that language between a health system and their EHR vendor and the patient's phone who just walked into that hospital. That's still a big gap that's up in the air that Apple will need to address, right? And there's a couple ways of doing that. It could be conversations with the vendors themselves. So how could they communicate and work directly with those EHR vendors? It could also be how do they work directly with the health systems? There is a lot of opportunity for someone like Redox to potentially connect those things up. And Apple isn't alone here. We need to get this data in the pockets of consumers, because they are the one common thing here moving between organizations. And probably our biggest hope in cutting costs in healthcare, if we change our behaviors, both from how we shop for healthcare as well as how we behave as humans, we can become healthier, right? That's something that hasn't been cracked yet, and we need on the magnitude of 10,000 developers throwing everything they have at it. And someone like Apple moving into the space is a big signal to all the developers out there thinking about, do I make the next calendar sharing application, or do I make the next healthcare application that I could use with my chronic conditions, or my family could use, or experiences that I've seen. And I think that's the only way we're going to be able to get through this.
Great. That's our next question.
Cool. So, Erin, I'm going to ask you this. Who the heck uses Redox now?
It's a great question. So today, we have well over 100 different applications that are actually Redox customers today that are either live at a health system or working on integrating with us, leveraging our API, working with our customer success teams to get live. Beyond that, we actually have thousands of people that have engaged with us either via our Slack channel or reviewing our API documentation, and are leveraging that as they build the next game-changing healthcare application. I'm excited to see what you guys are cooking up from there.
Yeah. So Andy mentioned in the comments that we have a gallery. So once a developer has created an application and has integrated it with our API, we allow them to post themselves on our gallery. So check that out. The link is in the comments here. And what the gallery is a subset of the applications that choose to put themselves out and say, I integrate with Redox, and therefore if a health system is also integrated with Redox, we get to a point where we can almost have turnkey deployment of that application. That's the ultimate goal here. But like I said, we are community focused. We want many developers working on this problem. So if you're a developer trying to figure out what is your best approach to making a healthcare application, consider Redox. But even if you want to do it on your own, join our Slack community. We have over 1,000 people now in our Slack community who are developers who are focusing on this problem, and the conversations that happen there are amazing. There are people sharing knowledge about the best way to log data for HIPAA reasons, the best way to host data for their healthcare applications, what languages people are using, what open source tools are out there that can be adopted. So check that out. It's really cool just to kind of even just watch and follow that conversation happening. Thanks for the question, Matt. Okay, so this one. So Matt's second question here: have you created a linkage between payer claims data and provider claims data? If yes, with whom, and some ideas of the process you went through to do it? That's a great question. So we definitely support claims data, and we support all sorts of clinical data. We normalize the standards that these data are sent in. So claims is all sorts of flavors of X12. Clinical data comes out in HL7 and CDA and FHIR in the future. So we have models where what Redox is doing is taking the data as it comes out of a health system and translating it into the standardized Redox experience of how that data is exchanged. So we absolutely support vendors now who need claims data. We support payers who are looking to get that data as well. The way that you can access that is you actually have to create a relationship with that entity. If you want to work with a big payer and get access to their claims data, that's not up to Redox to give you that data. That's up to you to work with that organization and create the agreement, based on whatever your business model is to get that, and we can enable it. We do not have the authority to give access to the data because we have to protect it, right? It's clinical information, and there has to be a known business association between the people who have access to this data and have to protect it and control it. So we can support all sorts of different use cases, including claims, including clinical data. It's going to be kind of unique to your product. So we're going to post information on the chat here about how to set up time to talk to us. And we'd love to talk to you about your product and figure out how we could potentially support it.
Cool. All right. The next one here is from Richard. What EMRs have been integrated by Redox? So today we've integrated with over 30 EMRs, a lot of which you've probably heard of: Epic, Cerner, Athena, Allscripts. A whole bunch you maybe haven't heard of, a lot of specialty EMRs and just those with smaller market share. But today we can really enable you to integrate with any EHR existing in the market. So whether that be cloud-based or not, on-premise, specialty, enterprise, small practices, we do it all.
Yeah, and the main approach that we take to this is it's our job to figure out how that EHR exchanges data, and whether it's coming out in some sort of format, whether they're dropping a file somewhere that we have to pick up over SFTP, whether it's over a webhook or MLLP traffic over a VPN. Like, that's our problem to figure out. There's a whole bunch of diversity in how that happens, but the developer experience that we want to give to developers is consistency between all of those things. So when people ask, who have you integrated with, we see that as that's a backwards looking historical view of where did it make sense to integrate based on the use cases that came up. And yeah, it's about 30 EHRs now that we've done in production. Looking forward, there could be all sorts of EHRs, startup EHRs. We've been doing our first integrations with Dr. Chrono, right? A awesome startup EHR company that has a very different way of integrating than does McKesson, for instance, right? So it's a wide spectrum, and it's something that, like we've said, interoperability is not a problem that can be solved. It's a moving target. And as the ways to solve it between different vendors change and evolve, it's our job to keep up with that. And that's all we do at Redox, is how do we keep up with those changes and move them into this standardized approach for the developer experience. So
that you as the developer don't have to.
Yeah. Oh, Richard here asking, how much experience does Redox have with FHIR? I believe that I went on a pretty encompassing rant on this earlier, so maybe this question has already been addressed, but Annie included some information there on resources that we have available. So we did another webinar specifically on Redox and FHIR, where we had James, our CTO, and George, from kind of a thought perspective, trying to understand where FHIR is going and how Redox works with it. So definitely check that out. We also have white papers available. So if you just like Google Redox on FHIR, you'll find it, where we comprehensively discuss how we fit into this evolution, and where we think it's going, and when we think it's actually going to be in a place where developers can use it. The contrast here is that our goal is to allow you to use what's available today, and if that's FHIR, that's amazing. We want to use it, but we're not going to wait, right? If you have a product that needs to go live at a health system today, and that health system and EHR don't have FHIR running, that's okay. We're going to figure out a way to get that data and turn it into a JSON web service API that you can use from a web development perspective. Okay, we got 2 votes here from Nick. Okay, so Nick's question is FHIR addressing the wrong problem. We've gone from a pipe and hat to XML and now JSON, but the real problem is consistent definition of what is contained in the data. I guess we should have read these questions before before we went on that rant. Absolutely, this is something we talked about earlier, but the actual contents of the data does need to be normalized as well. There's clinical normalization problems, right? What code set are we using to describe medications and procedures, RX norms, SNOMED, all these sorts of things. Clinical normalization is definitely a big problem that developers run into as you're trying to build a consistent experience. The other big one is actually much harder to solve, and that's the optionality in what a health system can do with their workflow. So each health system, at least from a large health system's perspective, they want to create the patient types. What is the discrete list of patient types that we have at our organization? A children's hospital is going to have different patient types than a large organization, and all children's hospitals are going to, they have their slightly different flavor, right? We might focus on pediatric oncology, where another might focus on birthing centers, right? Like, it's a wide spectrum of different types of patients, and each organization customizes that list. And from a developer's perspective, when you get that FHIR resources, that patient object, and it says patient type, who knows what's going to be in that field, because the health system has, maybe they have 40 options, maybe they have 5 options. At Redox, we maintain mapping tables where we say, this is what we know can come out of a health system based on working with them and understanding what all the possibilities are. This is what we're going to give you, and how they map into each other and what the logic is behind that, and making that logic consistent across the different organizations. So we do a lot of work in the normalization of this sorts of sets of data. Okay, cool. So it looks like we're running low on time here, and all right, okay, I guess we have a couple more questions here if I scroll a little bit more. Let's hop down to Richard's question. Please compare and contrast Redox with Apogee. Thanks a lot for that question. It's a common question we get, is how does Redox compare to Apogee or to MuleSoft or some of the other vendors in the space who are building APIs? It's an important problem to solve. We need easier access to the data, and the work that Apogee is doing is important. They're selling a product to a health system that allows the health system to build an API layer on top of their unique organization. So that's on top of their unique data center, their unique implementation of an EHR, their unique potential data warehouse where they might bring this data together, and Apogee can sit on top of that and normalize the data and make that available. What it's not doing is centralizing the access to it. So Apogee at one organization will look different than another organization. So they're making it a lot easier for the health system to start sharing that data, but from a development perspective, you're going to run into some of the same challenges, and it's definitely incremental improvement that we need to work with. But from where Redox fits into that is that when we work with a health system that uses an enterprise service bus type product like that, we actually will work with that product in a lot of cases as a different part of the stack. We'll hook into the APIs that exist and normalize that API experience for a developer, because we need to make that consistent between the health system that's using Epic plus Apogee versus the provider group that's using Athena and the out-of-the-box Athena APIs. Those APIs are going to vary wildly, and the functionality is going to vary wildly. How can we make a consistent developer experience? That's the problem that Redox obsesses over.
Yeah, that's truly vendor agnostic. Yes.
Yeah, from a vendor agnostic perspective. Cool. Great. Well, so I think that concludes what we wanted to get through today. There's a couple other questions that we'll answer in the comments as we follow up here. What I want to ask you to do, though, is if you want to have more conversations about this, if you want to talk specifically about the products and problems that you're trying to solve at your organization, reach out to us. Let us know what these problems are. We love talking to folks in the industry who care about this, and love trying to figure out how to help you solve those problems. If it makes sense to work with us, we'll gladly describe how that works. If it doesn't make sense to work with us, we'll tell you what we've heard other people try to do. We're not the end-all solution to this problem, but we can solve a lot of things. And the feedback from the market is how we drive how our product evolves over time. So we love talking to people about that. We'll post a link here as to how to get a hold of us, Annie threw the Slack link in there. So hit us on Slack. We'll also put information about how you can send us a note, and we'll set up a time to talk. Thanks for hanging out, and really appreciate all of you guys coming in.
Yeah, thanks guys. Have a good one.
Cool. It's probably going to take us a few minutes to figure out how to turn this off.
Stop.
There you go.